In Australia, it is widely recognised that the population is ageing and that age-related conditions are placing significant demands on the healthcare system. Governments, policymakers, communities and healthcare professionals have become increasingly interested in keeping the older population healthy and independent. Falls in older people are a significant predictor of disability, institutionalisation, marginalisation, mortality and socio-economic burden. Despite development of falls-related literature and innovative allied health programs, the fall-related demand on healthcare service providers has increased. Throughout my community engagement with Hawthorn Access Community No Falls program, I learnt that factors driving a person's risk of falling are complex and interrelated. Older people commonly present to emergency ambulance services after a fall for injury severity assessment. However, research suggests that approximately 20 to 40% of these people are not transported to an emergency department, nor are they referred to a community prevention service for further assessment. In brief, the primary aim of this proposal is for an interdisciplinary approach to high-risk falls patients, whereby Victorian paramedics will deliver referrals to pre-existing fall prevention community initiatives so that any patient's risk of falls may be managed in their community. This will mitigate unnecessary transport to emergency departments, ambulance reattendants and reduce the risk of falls. To understand the issue further, we are going to look at insights from 3 relevant perspectives. Falls and fall-related injuries are a major public health concern. Globally, falls account for significant disability and mortality and are the second leading cause of unintentional injury resulting in death. Australia and many countries worldwide have experienced a population demographic transformation whereby the proportion of younger people has declined and that of older people has increased. By 2056, the Australian Bureau of Statistics estimates that people aged 65 and over will make up to 23 to 25% of the Australian population. 28 to 35% of people aged over 65 fall each year. If the prevalence of falls continues in conjunction with the ageing population, the number of people presenting to ambulance services and hospitals with fall-related injuries can only be projected to escalate. Therefore, considering the profound burden that falls will place on public health services, it is essential that evidence-based research is used to inform effective ambulance service policy and practice. Older fallers present paramedics with substantial operational and clinical challenges. Approximately 25 to 40% of patients who fall are not transported, despite there being a lack of non-acute education, formalised non-conveyance protocol, and transportation to emergency departments being standard practice in most countries. Non-conveyance decisions are critical, as evidence indicates that poor health outcomes and repeat ambulance utilisation accompany non-conveyance in the absence of referral to alternative healthcare pathways. Routine referral of non-transported fall patients to community fall prevention programs is highly cost-effective from a public health and social services perspective. This is because it reduces the falls rate and fear of falling. However, paramedic preparedness to engage in the referral of older people who have fallen has been questioned. Rationale offered includes the relative isolation of paramedics in relation to other allied healthcare professionals and thus utilisation of interprofessional practice frameworks such as referrals. Furthermore, ambulance operational demands mean that paramedics feel constant pressure to be available for high acuity work and thus experience conflicts regarding the time necessary to provide alternative referral pathways to low acuity patients. Poor education has affected paramedic confidence and willingness to make decisions about conveyance because they fear the potential likelihood of litigation. Clearly, employers, education and training need to support paramedics in making confident decisions about how to best provide safe and effective healthcare to older people who have fallen. The factors influencing an older person's risk of falls are complex and dynamic. Some primary risk factors include sensory decline, sedentary lifestyle, past history of falls, inappropriate footwear, low socioeconomic status, living independently, and medications such as sedatives, analgesics, and antipsychotics. Age-related decline, such as musculoskeletal changes and joint weakness, mean that older people are more susceptible to severe fall injuries, such as fractures. Progressing age and frailty increases the longevity of hospitalisation subsequent to fall-related injuries. Consequently, fall-related injuries frequently initiate movement into assisted living facilities, which results in institutionalisation and loss of independence and autonomy among older people. Social isolation, loneliness, and depression triggered by a lack of social participation are inversely related to functional decline and an increased risk of falls. Conversely, fear of falling is a risk factor for future falls. This is because maladaptive changes associated with the fear of falling reduce daily activities that are needed to maintain self-esteem, social interactions, and physical conditioning. Keogh has found that participation in age-friendly, community-based exercise programs have the capacity to socially re-engage older people in activities and thus improve their quality of life. The human and social costs of falls on the older population is significant. Developing strategies that minimise the impact of risk factors is an important step in ensuring successful active ageing. This practice modification will provide a direct referral pathway to patients who have fallen and been triaged by Ambulance Victoria paramedics as not requiring ED admission, due to them being uninjured and having vital signs within normal physiological ranges. This proposal will require the collaboration of Ambulance Victoria with all available community fall prevention programs across the state of Victoria. Ambulance service employees will be provided with fall-specific education and training outlining the referral processes and recognition of appropriate patients for non-conveyance. Paramedics will be able to access referral contacts on their VACAS Toughbook or Ambulance Victoria Clinical Reasoning app. Service partners will provide individual outcome reports to referring paramedics in an attempt to encourage paramedics to sustain the rate of referrals. Community fall prevention programs will provide a range of assessment and treatment options, including strength and balance training, home hazard recognitions, equipment and home modification, medication review, and social care from a multidisciplinary falls service team. This collaborative practice will be mitigating the challenges of older fall patients by improving patient health outcomes through a strengthened health system approach. Planning, consultation, and communication, informed stakeholders, leadership, and effective evaluation strategies are factors critical to the successful implementation of organisational change. The following information will provide a more in-depth overview of the phases involved in this process. Phase 1. Build partnerships and collaborative action. Recruiting the assistance and collaboration of community-allied health fall prevention programs statewide is a crucial step to ensuring that the appropriate level of interdisciplinary action and resources are available to individuals who are at a high risk of falls. The process of contacting and enlisting the collaboration of all appropriate community fall prevention programs across the state is a large undertaking. Therefore, it would be most appropriate that Ambulance Victoria recruits a networking director and team of assistants that may undertake this process. This team would also be responsible for keeping an up-to-date record of the contact details and locations of established partnership programs. Phase 2. Prepare referral infrastructure. An online referral directory and electronic consent form are the primary infrastructure required by this proposal. The online directory will be a culmination of all the information regarding relevant allied health partners so that paramedics can access referral information in a timely manner. Consent is a necessary process ensuring that patients, the primary stakeholder, may be informed of the referral process and agree with the terms that their personal information will be shared with third parties. An electronic consent form for the referral to community fall prevention programs built into pre-existing VACUS program will mean that paramedics can explain to patients the referral process, let them read the consent form and obtain their signature if they choose to consent to the referral. Phase 3. Implement workforce training and education. A pilot fall referral program was deemed unsuccessful because of poor utilisation by paramedics. Of the limited patients referred, many were inappropriate for the service because of diagnoses such as dementia, terminal cancer, and end-stage Parkinson's. The literature shows that a lack of emphasis on disease and injury prevention, health promotion, and public health in paramedic education have led to organisational norms and barriers that impede the uptake of referrals. This has perpetuated feelings of frustration towards low acuity work involving people who have fallen. In order to provide safe and effective care, it is necessary that paramedics be provided with a sound education regarding falls in older people, so that they may understand the complexity of fall presentations and therefore make clinical judgments regarding the most safe and effective care for the patient. Phase 4. Data collection and proposal evaluation. It is necessary to build evaluation strategies into this proposal so that the effectiveness of the practice modifications can be established. The evaluation process will utilise call taker triage data and ambulance case records for adults aged over 65 for baseline measurement of falls prevalent prior to the proposal implementation. This data will be compared with the same data post-proposal implementation. Data analysis will determine if the referral falls patients attended by ambulance has the capacity to reduce the incidence of falls and repeat ambulance attendance in community dwellers over the age of 65. A secondary evaluation measure will involve client satisfaction surveys after their participation in the referred falls prevention program. This will provide valuable feedback regarding the program's ability to improve patients' quality of life and reduce the incidence of falls. Emergency medicine researchers unanimously agree that there is a lack of evidence regarding the effectiveness and viability of alternative pathways and models of care for non-transported falls patients, and that the implementation of these is an area for further research. Falls training and education will enable Ambulance Victoria paramedics to feel increasingly confident about their ability to provide care to older people who have fallen. Furthermore, a better understanding of the falls risk factors and capacity of allied health fall prevention programs may reduce the incidence of inappropriate referral decisions seen in the QAS referral pilot program. Successful referral processes eventuate in older fallers' participation in community fall preventative measures, will have mutually beneficial consequences for Ambulance Victoria, healthcare services and the non-transported fall patient, whereby the associated reduction in fear of falling improves quality of life and protects against functional decline, social isolation, depression and anxiety. Ultimately, this should reduce older fallers' utilisation of healthcare services and provide greater value for the given expenditure. This proposal has serious implications for resources, as education measures will need to be provided at regular intervals and community fall prevention measures may be non-existent or inaccessible in regional areas of Victoria. The modifications associated with this proposal align with current evidence-based practice regarding fall prevention and make use of existing community resources, which is supportive of Ambulance Victoria's pre-existing commitment to community engagement, whereby building community participation in fall prevention programs will result in health outcomes that reduce falls' financial and human burden on older people, hospitals and ambulance services alike.